we're in this wonderful era of immunotherapies in myeloma. We're seeing unprecedented response rates in late line patients with CAR T cell therapies, with immunotherapies. And I think that there is room for all of these strategies, whether it's CAR Ts, bispecifics, or the combination of different bispecifics, or combinations of bispecifics with other immunomodulatory strategies. If we were in utopia and we had unlimited capacity, CAR Ts would probably be the preferred choices of treatment for patients because you're able to deliver a dose, and then patients recover and they're not on any maintenance therapy, so that there's a different proposition of quality of life after that initial phase. Whereas with bispecifics, it's more of a continuous therapy model. There are also inherent challenges with manufacturing CAR Ts. It takes a while for us to collect the cells and then manufacture, and during that time, for a month and a half or two, we still have to control the patient's disease. And then there's the safety profile component as well. So there are pros and cons to CARs and bispecifics, and I think in the future, what we're going to be looking for is patients who are CAR eligible versus not, and picking treatments appropriately. And then for CAR eligibility, access would be also an important piece. How far away the patient lives from, the cellular therapy center. Do they have the social support and mechanism and infrastructures to, help them take through that particular strategy? So, I think, it's a good problem to have. I think, both of these therapies are very important, and they will help us, get better survival outcomes for, many more patients than we do today.